I was born in Karachi, Pakistan. Therefore, it's even a privilege to be even able to go to school in Pakistan because there are so many kids who don't even make it to that stage. The thing about medicine that always attracted me was that you can really make a big impact on a personal level. A lot of our patients don't have the financial means to pay for it. So I had the knowledge, but yet I was unable to use that knowledge to provide the care that my patient needed.
And as we were resuscitating, we were bagging them out. Feces came out of every orifice, from the mouth, from the nose.
The US has been facing a shortage of physicians for a long time.
It says that every patient is a walking lawsuit.
So there is defensive practicing in the US, and that's done by all specialties. The reality is that medical education in many countries in the world still lags far behind many of the developed countries. What I want to do is to shatter this myth that medical education can only be provided in a medical school or medical college.
Join Disruptive Doctors.
I'm Dr. Selena, your host and co-founder of Disruptive Doctors. At Disruptive Doctors, we're building a platform to help doctors like you impact healthcare differently. In Post-Call, we dive into the untold stories of doctors who are breaking the mold, trailblazers who are redefining what it means to be a doctor. This is Post-Call Beyond the White Coat.
Today, we're diving deep into the story of a remarkable physician, educator, and innovator, Dr. Kashif J. Piracha. From growing up in Pakistan to making a mark in the United States healthcare system, his journey is anything but ordinary. So we're going to unpack the struggles, the triumphs, and the lessons that has shaped the man behind this white coat. Dr. Kashif, welcome to the show.
Thank you, Selena. Thank you so much for inviting me. I'm very happy to be here.
So let's, from the very, very beginning, tell me, what was it like growing up in Pakistan, and what were the challenges you faced during your formative years?
Oh, yes. Yeah. Thank you so much. So, yeah, it's a long story. And basically, I was born in Karachi, Pakistan, the biggest city in Pakistan. And then I spent my early childhood in a town called Hyderabad, which is a couple of hours drive from Karachi. Basically, Pakistan, as you know, is a developing country, and there are lots of social challenges, and the literacy rate is around 30% at the best. And therefore, it's even a privilege to be even able to go to school in Pakistan because there are so many kids who don't even make it to that stage. But I was fortunate that my parents got me enrolled in a very good school, which actually laid the foundation for all my success down the road. And I had good teachers, and I worked hard. I always had good study ethics. I wanted to make sure that I complete my work on time and stuff like that. But still, competing on that stage was also challenging. And then once I completed high school, then it was time for me to get admission in the medical college. And for that, obviously, I needed to score high in my high school exams, which I did because in the Hyderabad division, from where I was competing in the high school examination, I had the third position in the whole board of education, which was very helpful. And I was able to get admission to one of the best medical colleges in Pakistan, which is King Edward Medical College in Lahore. And then I completed my medical degree from over there, graduated in 2000. When you talk about challenges, challenges in a way that I didn't grow up in a very lavish environment. My family at best was a middle class family. My dad had a job, but he was not like a CEO or executive or very highly paid professional. So we had some struggle in those days. He was always very focused in making sure that he provides his kids with quality education, which I think one of his priorities was always that, which was very helpful because that really laid a good, strong foundation for me. But again, the challenge is one of the challenges that you would have that's not just in Pakistan, that is probably going to be anywhere in the world that, if you want to become a doctor, it's never going to be easy because it will require hours and hours of studying and so you really have to be very disciplined to do that. And I think a lot of people face difficulties when they try to be that disciplined because it takes a lot of courage. But if you set your eyes on a particular goal and you are determined to reach it, then you would find a way. But you have to stay disciplined throughout the course.
So, Dr. Kashif, earlier you mentioned that Pakistan had a 30% literacy rate, and not every kid gets to go to school. What is the criteria for someone to get into school in Pakistan and receive an education?
Yeah, basically, so ultimately, at the end of the day, Pakistan does not, and some of my knowledge may not be completely up to date because I've been out of Pakistan for about 25 years now. But based upon the knowledge I have, it is not mandatory for parents to send their kids to school. So ultimately, it all depends upon what are the priorities of the kids' parents, what kind of financial situation are they in, and do they have the means to provide for the books and the studying and the school fee and all of that for their kids to even be able to go to a school. Now, obviously, there are different types of schools. You can have private schools, which are more costly, and then you can have government funded schools, which are less costly. So ultimately, it all depends upon the financial means that the family has, as well as the priorities of the parents. And unfortunately, many kids don't make it to school because of financial hardships or the circumstances that they are growing in. There is a lot of poverty in Pakistan, which is not just limited to Pakistan. This is the problem of the whole developing world. And most of the struggles are probably the same in many different countries where you go.
Okay, so now you've studied really hard and you go into medical school, but what made you decide medicine is the path for you, or was it just because it seemed logical?
No, that's a great question. It's not logical, and it was a very carefully calculated decision. And the issue was that I always wanted to make a positive difference in people's lives. Now, that's not just medicine. Like I give you an example, you can become an architect and you can build homes for people, and you're making a difference in their lives because you're providing a house for them to live in where they can live and prosper and share memories. So that is not in any way a minor difference in people's lives. But the thing about medicine that always attracted me was that you can really make a big impact on a personal level. So to give you an example, like if you think like you're having a bad headache, I'm sure all of us have had like a terrible headache at some point in our lives, right? Just think about the day you were having a really terrible headache. Then what happens is that if you're really having a terrible headache, then all the money in the world and all the facilities you have and all the luxuries you have, you cannot enjoy them because you're in pain. The food would not taste right. If you're traveling for vacation, you wouldn't enjoy that. There's something about medicine that actually impacts people at such a personal level that I think there is no other profession that does that. So, and I always thought that if you take somebody's pain away, I mean, that's probably making a difference at the most basic level. But then the realization that, as times are going by, we are getting more research in medicine and we are coming up with new treatments. And so there's always going to be a need for more doctors because obviously the landscape of medicine keeps changing too. So with new treatments, there are new specialties like genetics is a relatively new specialty. And it's only going to get more and more advanced in the future as we know more about the chromosomes and DNA and the genetic treatment for autoimmune or congenital diseases. The reality is that medicine has a very broad scope, and there is a lot of room where you can make a difference, and you can make a difference at a very personal level. And I think that aspect of medicine is not found in any other profession. And I always wanted to make a difference at a personal level. So that was one of the reasons that pushed me towards becoming a doctor.
Oh, that's very interesting because as you were talking about that, how it really affects someone at a personal level. I remember years ago, actually in 2014, I think, I took a hike in the Himalayas in Nepal for a month. So I trekked through a lot of small villages in the Annapurna circuit. And I also got a privilege to live with the villagers for a short period. So a lot of things that you were saying, like, kind of brought back these memories. I've followed kids to school. They had to hike 2 hours a day. No, 2 hours to school and 2 hours back from school. I was just thinking how privileged I am. I had a bus to pick me up, send me to school. Because when I was there, I followed those kids. They got up at maybe 4 a.m., prepared. They had to do their chores. When they're done with chores, it's around 6 or 7, and then they started hiking. So, because we lived with the villagers, so I had to follow. I could follow them to the next village. Wow, they had so much determination to learn. I'm just thinking about us here in we're considered developing, but we've got a lot of facilities. We've got cars, we've got private drivers, we've got buses. We just have to get up and sit in the bus, and there we are in school. But these kids are very determined, and they have to put in the effort to get to school. And the class is full, even though it was so cold, it was freezing. But when I reached the school, I just took a look. The classroom was full. It's small, but it was full. So I can see that we take a lot of things for granted, which, like, people from your country and around that region, the poorer countries, the less developed place, really have to strive hard to achieve. And while I was there, I guess I managed to, while I was there hiking, and there was a village I stopped in. The baby was sick. I was having very bad diarrhea. They don't have medication. They don't know what to do. And I gave them whatever medication I had. And the next day, the baby was much better. And at the time I was practicing, and I think I felt a lot of sense of satisfaction that I managed to impact another person's life.
Yeah, you see, that's the thing. That's just unique to medicine. I mean, you impact people at such a basic level that that's something that only medicine offers. No other profession does that.
Okay, so after you graduated, did you ever work as a doctor in Pakistan?
Not really, because I was focused on doing the USMLE, United States Medical Licensing exam, and coming over here. I did work, but for a very short period of time. But after graduation, I took the USMLE, which I passed, and then I moved to the US to get residency and start practicing as a doctor in the United States.
Okay, before we get into like preparation, USMLE, what made you decide to leave Pakistan and go to the US? And if you did practice in Pakistan, what was it like there, being a doctor there?
So basically, the biggest difference is the facilities and the access to latest medical technology to practice. Now, the thing is that the problem was that when I was still in medical college in Pakistan, and we used to talk about all these imaging studies like CT scans and MRIs and biopsies and pathology and blood cultures and urine cultures and stuff. And you read about all of that, which was a common occurrence in many countries in the world. But in Pakistan, basically, the healthcare system was that the patient has to pay out of pocket for all imaging, all lab tests, all cultures and everything. And a lot of our patients don't have the financial means to pay for it. So then you get into a situation where and as you know, you being a doctor, in order to make an accurate diagnosis, you need certain data to make an accurate diagnosis. History and physical exam can only go so far, but we have laboratories, we have imaging. In the United States, there are quite a few diagnoses that I make on a daily basis, which are based upon imaging technology, like CT scans, MRIs, ultrasound. all that kind of stuff. So the problem was that there was a disconnect. So I had the knowledge, but yet I was unable to use that knowledge to provide the care that my patient needed because I didn't have all the data that was needed to make an accurate diagnosis. So a lot of times now you get into a situation where you cannot make the accurate diagnosis. So you have a broad differential diagnosis, but you can't pin it down. So the problem is, what do? Then you end up, sort of treating everything, right? Because if your differential diagnosis is like 5 diagnoses, now you're treating all 5 of them. A lot of that is useless for the patient because they only needed to be treated for 1 out of 5. But because of limitations, you are not able to get down to that one primary diagnosis. So that was one of the reasons I wanted to put into practice all my knowledge. And then I realized that if I practice in the US, where we have the ability to get these tests done to make an accurate diagnosis, then I can provide more efficient care. And that was one of the reasons. And it was, in fact, one of the main reasons because I wanted to make sure that, the kind of care that I'm providing is actually up to the level of exactly what is being practiced around the world at that particular moment with all the technology that is available to make sure that you deliver the kind of care that you have been trained to do.
That must be quite frustrating because I graduated in Indonesia. While I was in Indonesia, I was doing the 2 years of our final years, we were attached to hospitals. There were so many things you can do. It's practically a cowboy town because a lot of things you just have to make shift and make do with or find alternatives. And like you said, it's true. We couldn't really exactly pinpoint what it is because they had to pay out of pocket. And it was, how did that affect you? Because for me, when I was in that situation, I felt really hopeless. Like as a doctor, I could not do much for my patients. There were many procedures I couldn't do for them as well because it was out of pocket and they couldn't pay for it. My first day working in the hospital in Indonesia, I lost the baby because a baby came in with imperforate anus, and the moment the baby arrived, just a short few hours, she went into cardiac arrest, and we tried to resuscitate. And as we were resuscitating, we were bagging the mouth. Feces came out of every orifice, from the mouth, from the nose, and they could not pay for like intubation and sending the baby into the ICU. I felt so hopeless. I was resuscitating a corpse because there's really nothing I could do. As we were doing chest compression, more and more feces were coming out as I was bagging, like even more, it was just feces everywhere. Like there was nothing we could do for the baby. And that was my experience being in a third world country where they were so poor they couldn't afford healthcare. What was it like for you when you actually went through that? Was there anything in particular that really made you realize that, okay, I cannot stay here because I cannot really do what I was training for?
I mean, that's exactly what you said. That's exactly how things are in Pakistan. That's exactly how things are. I mean, you don't have, like in the US, one of the things we talk about, came to the US, and here you have the full resuscitation protocol where when I got here and they trained us, and they said advanced cardiac life support, we call it ACLS here, or basic life support, we call it BLS. And you have to get trained in that, and they take you through a series of questions like, you have to find out if it's a respiratory arrest or is it a cardiac arrest. Then you have to figure out if it's a cardiac arrest, is it like asystole? Is it pulseless electrical activity? Is it ventricular tachycardia, ventricular fibrillation? And then there are different treatments for that. And I was so amazed because when I was in Pakistan, there was nothing like that. You not even a proper protocol where you would resuscitate patients. So obviously, like I said, I mean, the limitations exist at many different levels. I mean, you talk about a pediatric patient, and so you can take any kind of patient population, and you will see that there are just so much limitation about what you can do. And then one of the major problems with that is obviously the cost associated with it. And then when you have to pay out of pocket, a lot of times, there's only limited amount of things you can do. So then the problem comes that as a physician, when you have to make a decision, should I order X test or should I order Y? Because they can either pay for X or they can pay for Y, but they can't pay for both. And what about you order X, but you still can't make a diagnosis? And then you're stuck. Then you think, oh, maybe I should have ordered Y. As a doctor, you should not have to make these kind of decisions. You should be able to get what you need to get to where you need to go, proper diagnosis and treatment. But, we are only talking about diagnosis here. Suppose you have made a diagnosis, but the treatment is costly too. Treatment is not cheap either. And there could be a first-line drug and a second-line drug and a third-line drug. So, there are lots of barriers, right? So, you feel as if your education, you're not doing justice to the education that you have received if you can't put it into practice, because ultimately what will happen? I will tell you what will happen. What happens is that over a period of time, we only remember the things that we do in our everyday routine. Like I can tell you exactly, just look at it this way, we talk about different specialties, go and ask a gastroenterologist after they've been in practice for 10 years, how much neurology do they remember or how much rheumatology do they remember, right? They won't remember that much because, that's how the human mind is trained to do. You learn things, but then the things that you keep doing on a regular basis, you remember them more, and the farther you go from things that you've learned many years ago, and that's why repetition is important. But the challenge is that suppose you have this education and you know how to make a diagnosis or treat a patient, but if you don't have the necessary means to do that and you don't do it, and you don't do it for 10 years, guess what? You're going to forget how to do it. Now you are 20, 30 years behind because the thing that was the norm 10 years ago, now 10 years later, you have even forgotten that, and the world has gone 10 years ahead of that as well. So just like you said, there's a lot of limitations, and it's just not, you just don't feel like you're doing justice to your profession.
Yeah, that makes sense. Now, when you decided, okay, I'm going to go to the US, I'm going to take the USMLE, what was your prep like? 20 years ago, and plus you're from Pakistan, I'm not sure what the internet was like. Where do you even get your information from? How was that process?
Oh, yeah, that was very challenging. There was the internet started, I think the first time I had an email was like 98. I graduated from medical college in Zen. Internet was in its infancy. I didn't get any help from internet for the USMLE. First aid was still there. So I studied first aid. There were just some books. Most of it was just information passed down to me by people from my medical college who were 2 years ahead of me, who had just taken the USMLE. They just told me the resources that they used, and basically I just used the same. But I didn't have access to any online quiz bank. There wasn't a word. The word Q bank had not been invented then. There was nothing like a Q bank. So anyways, it was an interesting experience. The other problem is that the USMLE is a multiple choice question exam. And when I graduated from Pakistan, we had the essay system. So you have to write, it's not a multiple choice question system type of examination. They give you a problem and they give you one big problem and you have to write a detailed essay covering the diagnosis and physical signs, symptoms, and treatment. So that format was absolutely not helpful. So I had to start from scratch. Like I completed my medical college and then I sat down and I did the step 1, which is basic sciences. I had to do all the anatomy and physiology and microbiology, all of it again. So it took like 6 months. So I did 6 months prep for step 1. I did 6 months prep for step 2. So that's how I did it. Now, and that was the norm back then too. Most of the people from my medical college were studying anywhere from 4 to 6 months, dedicated preparation for the USMLE. Like we would study 12 hours a day, and it would take 4 to 6 months preparation to do the USMLE. No, obviously these days it's much easier because you have so many tools at your disposal. You can grade yourself, but there was nothing like that in those days. But that's how I did it.
So if now someone wants to prep for the USMLE, do you know how, like, what should they do? What would your advice be for them? Like, how can they prepare for it?
Oh, yeah, but I can advise them very well because actually I teach medical students now in the US, and they are the ones I'm teaching them internal medicine, and they go and take the USMLEs. But um, basically, the most important thing is, again, I mean, the principles will never change with medicine. You have to make sure that your basic foundation is strong. It's like building a house anyways. So you lay the foundation with anatomy, physiology, biochemistry, microbiology, the basic sciences, and then you keep building the building has to go up where you put internal medicine and OBGYN and surgery and psychiatry. But what I would advise students to do is, I think the best way of learning is, one of the best ways of learning is to do questions and then do them very thoroughly. Well, one of the things is that, suppose if you're doing a practice question, and if the practice question has four wrong answers and one right answer, actually that's five questions. That's not one question, because all those four wrong answers are actually a correct answer for a slightly modified question stem. So anytime you do a question with one correct answer and four incorrect answers, look at it as five questions. So what I tell my students, say, look at it this way. You pick out the correct answer. The correct answer is going to be the one that will match the best with the information provided in the question. That's why it's the correct answer, because most of the questions are most likely diagnosis, best treatment, stuff like that. But then what you need to do, what the smart student would do, is to take the same stem and see what information in the stem has to be modified for all of those incorrect answers to become correct. So basically, what I was saying was that I tell my students that you basically make some modification to the stem of the question and then make it so that each one of the incorrect answers could become the correct answer. And all of a sudden, you have five questions out of one question. The problem I see with some of the students is that the problem is always like not having too many resources is a problem, and not having too many resources is also a problem, because then you don't know exactly which one to use and how much. So the problem I see with students is that they try to do just too many Q banks sometimes. And that's not really good, because what happens is that you can't focus very well when you have too many things on your plate. So you need to cut down. You need to choose one Q bank, but you need to do it thoroughly and make sure that you understand each and every question. So I think a lot of it is like you have to take a look at the USMLE preparation as a marathon. It's not a sprint. So you need to pace yourself, because you can get really burned out if you go very fast in the beginning. Having a schedule always helps. And I think the successful people have the whole thing laid out as a roadmap, and then they pick and see which things need to be done at what time. And in the end, you summarize everything. And I think that gives you the best possibility.
Okay, so after you graduated, you sat for the USMLE, you passed. Now, how did you get from Pakistan to US? Did you have to get a job first, or did you just wait, bought a ticket, went to the US, and then see what happens?
Well, I mean, if you are a foreign graduate, you can come to the US because of your qualifications. And actually, the Educational Commission for Foreign Medical Graduate, ECFMG, actually sends you a letter that you can even take to the US Embassy to facilitate your coming over to the US, because they know that you are a physician and that you have all the documentation that you are going to take the USMLE, and you have all the letters and stuff. So you have a lot of documentary evidence that you are going there for a professional reason. And that's how I got here.
Okay, so does that mean that you don't exactly have to get a job first?
You don't exactly have to get a job first, because, if you are taking the USMLE, then once you're done taking the USMLE, it depends upon if you get matched into a residency program immediately or not. but there are ways that you can still come over without having to need to have a job before coming over.
Okay, so how did
But
what was your
but times
process
have changed, so that things keep changing.
what was the process like for you to get the job or get into the residency programs?
So basically, you take the USMLE, you pass the USMLE steps 1 and 2, and then in those days when I did it in 2002, they had a clinical skills examination. They used to call it a CSA, clinical skills assessment, and you pass that. And once you've done the step 1, step 2, and CSA, and you've taken the TOEFL, a test of English as a foreign language, and you've passed all of those, then you can apply for residency. The good thing was that the match was already established. In fact, I was lucky that there was a match. The ERAS, Electronic Residency Application Service, and match had already been in place, because I know some of my friends who were 5 to 10 years ahead of me back in the 90s. There was no match. So they had to send their application individually to each and every US hospital along with all the documents. And that was a big struggle. But the match was already in place. And the good thing about the match was that you just have to send all your letters of recommendation and documentation to the ERAS. And then you just check a box and they send your letter. You just check a box. You tell them, send this letter of recommendation to this program, this one to this program, this one to this program. So it was already there. And that was a big help. And then ultimately, money is again a factor, because applying to different residency programs, the more programs you're going to apply, the more money it's going to cost. So you have to be strategic about it. So what you really need to, there are a lot of things, even back then in 2002 when I was applying, what were the things that were going through my mind? So the thing is that you have to know which programs you have a good chance of matching at. So it depends upon a lot of things. It depends upon the specialty that you're trying to match in. It depends upon the region in the US where you want to go and do the residency. It depends upon the competitiveness of the program where you are trying to match, and the specialty. So there are a lot of things into consideration. So you get a good idea about which programs you have the better likelihood of matching, and that's how I apply. I applied to those programs which were a reasonable option for me, depending upon the specialty that I wanted to do and the region of the country that I wanted to live in. And so that's not a universal advice, because that will be different for different people, depending upon what their specialty is and where they want to work. But again, at the end of the day, the more programs you apply to, the more you have to pay. And depending upon how much money you have at your disposal, you may have to sit down. And I went through every single program. I printed all of them out. I highlighted them. Then I looked at how competitive they were and all the factors that I just told you. And then I decided which ones I was going to apply.
Is the process still the same? Like you still have to just search for a residency program to be matched with?
Yeah, it's mostly the same. Of course, now we have many more residency programs as compared to when I did it, because it was more than 20 years ago. But I just wanted to take this opportunity to also educate people that the US has been facing a shortage of physicians for a long time, because the rate at which our population in the US is growing is also not keeping pace with the number of doctors that are present in the community to take care of those patients. So basically, over the last couple of years, many states have come up with new laws that actually allow foreign or international medical graduates to be able to practice medicine in the US without even doing a residency. Now, this is not a carte blanche. There are some limitations. They may have to work in a supervised setting for a few years. They may have to work in a rural area for a few years. There are going to be some adjustments that are going to be required, but it is still a much better option, because I know that there are many international medical graduates who really love and really want to practice in the US, but cannot do that because ultimately, unfortunately, they were unable to match in a residency program. And so one of the things that I think the new laws require is that you must have done some training, residency type training. What I'm talking about is some sort of clinical training after completing graduation from your medical college in your host country, but you may be able to come to the US and work as a doctor even without doing the residency. Now, in the US, the medical license that's given is actually given by every state. So there are 50 states, and every state has its own medical license. So therefore, the requirements for the international medical graduates to practice are going to be different based upon which state they want to go and which state they want to practice in. And not all the states are offering this option right now, but the door has opened, and I think as time will go by, more and more states will join. So that's a very good piece of news for a lot of international medical graduates anywhere in the world. And I think whoever wants to take advantage of that, then they should really look forward towards it.
Where can they find this information?
So it's available. So what you really need to do is that you can just put in the name of the US state, and you can go to the state medical board website. Every state has a medical board. I practice in Texas, so there's a Texas medical board. And basically, every US state has a medical board. And all you have to do is to go to that state's medical board website and look at their requirements. And then you can find if there are pathways that are offered to international doctors that don't require residency. And all of the criteria and everything is going to be there. Now, they will require passing USMLE and everything else. So the only relaxation is you don't need to go through the residency, which is the biggest stumbling block for a lot of international graduates.
Okay, that's a good piece of news, because for a very long time I understand that it was very difficult for medical graduates to get into the residency program, even though they passed the USMLE.
Right. Yeah. That's why this is such a big piece of news. I mean, this is life changing, and it's a very big relief, and it is going to help not only the international graduates, but it's going to help our patients here in the US too, because we do have a shortage of doctors. One of the things that we look at is that we always talk about problems of developing countries, but I think a lot of problems that the developing countries have, the developed world is also faced with those problems, but the magnitude is different. So what I'm trying to say is that the growth of population is exceeding the growth of resources. Now, what's happening is that the growth of population in the developing countries is exceeding the growth of resources at a much larger scale. But again, the developed world, including the US, we also have the growth of population is exceeding the growth of resources, just not by that much in the developing world. So I think this foreign graduates coming here and practicing without residency is going to help a lot of patients in the US as well. So it's a win-win on both sides.
Okay, before we dive into what your experience is working in the US healthcare system, let's talk about you leaving home, your community, a support system. All you knew was Pakistan. It must have been incredibly difficult. So what was the journey like moving to US and actually finally getting into the US? Was it everything you thought it would be?
Well, for the most part, I got a lot of what I expected. But again, it's not easy, right? So the way of life in the US is radically different from the way of life in Pakistan, as it would be the same for many developing countries in Asia. One of the advantages I had coming to the US was that I did not really face much problem with language. So language is a big problem, right? Because that's how you communicate with people. So if you don't know the language of the country that you are going and you have difficulty communicating with people, that makes everything 10 times harder. Because first you are already new to an area, and then you don't even know how to ask people for help. That just makes it 100 times difficult. The good news is that English is the official language in Pakistan. And I was I studied English starting from pre-K, even in kindergarten. I always knew English, and I was able to speak fluently and communicate and write in English very well. So taking the TOEFL examination for me was just like checking a box. It was really just an exercise that I had to do, but I didn't have any difficulty doing it. So that part was much easier. But then the other thing is that if you look at it this way, that coming to a new place is always difficult. But one of the things is when you start working in residency and you start working as a doctor, you're so busy that you really don't have much time to do anything other than just go to the hospital, see the patients, go back home, take a shower, eat food, and go to bed. I mean, residency is a very busy schedule. I mean, you barely have enough time to scratch your head. So there's not really a lot of other things you can do other than just seeing patients. And if you are a doctor in your home country, you can do that. Now, the issue is that some of the things that you really have to be careful in the US as compared to when you're practicing in Pakistan is that the way the healthcare is practiced is also very different. And in the US, there are laws about patient privacy and consent and a lot of things that you have to be mindful. Also, there are malpractice situations in the United States where you have to be mindful of the way that you are practicing to make sure that you don't expose yourself or your hospital to any situation where there could be a malpractice litigation. And those kind of concerns don't exist in Pakistan, or at least didn't exist when I was there. So it's an adjustment. But if you remain focused on what you have to do and you try to do the best job that you can do every single day, then there's no reason that you cannot succeed. Because ultimately, one of the good things about the US is that if you do put in the hard work, you do get rewarded. Now, not to say that there are no challenges, but if you do put the hard work, sooner or later, you will make your way through. And I had adjustment difficulties, and almost everybody coming from other parts of the world has. But again, just because you stay so busy taking care of patients, there's not really a whole lot other things to do.
I like how you brought up the differences in the culture. I think I came across a book quite a while ago. It says that every patient is a walking lawsuit. It's definitely written by a doctor in the US. Is that the mindset there?
Well, not necessarily, but again, the thing is that there could be malpractice is a very broad topic and probably would require a long conversation just about itself. But the reality is that you have to remember that even if you provide the best treatment, you will not be able to cure every patient. There are some people who are going to have a bad outcome, even if all the best treatment in the world is provided. So what happens is that whenever someone has a bad outcome, then obviously they are unhappy and the blame game starts. And it's easier to blame people. It's easier to go through any case with a microscope, with a magnifying glass, and try to find mistakes committed by the healthcare team. So that way it is challenging. You have to make sure that you do everything that you're supposed to do as a doctor. But again, medicine is just like anything else. You can never guarantee any kind of outcome because as a doctor, you can only provide the treatment, but ultimately the treatment is not going to work in each and every case.
Do you feel that the way medicine is practiced in the US is very defensive, where you're sort of walking on eggshells, making sure that you do everything? It may be right in the book, may not be the best for the patient. Do you feel that that's how it's practiced there?
Well, not to a very large extent, but actually some of it is. So there is defensive practicing in the US, and that's done by all specialties. And obviously, the thing is that if you look at clinical criteria for any kind of disease, most of the defensive practicing that's done is in imaging or excessive imaging, doing scans and stuff where the likelihood of finding positive outcome is very small. But the thing is that if you look at it this way and you say that 90% of the people are not going to require this imaging test because this imaging test is not going to be helpful, you can just rule out the disease in 90% of the people by doing a history and physical exam. Well, the problem is that the 10% in which that imaging is necessary, if you don't do it and they have a bad outcome, well, then they're not going to be happy about the fact that if you tell them that, oh, I didn't do a CT scan on you because, 90% of the cases it's not good. And they tell you, well, I was one of the 10%, so guess what? You didn't do it in me, and I have a bad outcome, so I'm coming after you. Because at the end of the day, care is personal to everybody. Somebody once told me, he said the test result is great. Like test mean an exam, like as a medical student, you're taking an exam or any kind of exam. And he said, well, guess what? The results were great. 98% of the people passed. So he said, okay, hold on a second. There is no good or bad result. The one who passes, everything is good for him. The one who fails, everything is bad for him. The one who fails doesn't care 98% passed. He was in the other two. So that's all that it's the worst result for the one that failed, even though 98% passed. So you see, so that's kind of the way that you have to have that kind of mindset to make sure that you are covering yourself in every possibility. And that does lead to some defensive practicing of medicine. And that's something that is a challenge. And I think at some point will have to be addressed, even in the United States, to reduce the healthcare cost, because defensive practicing does cost a lot of extra money to the healthcare system in the US.
Before we dive back into this incredible conversation, there are a couple of exciting opportunities with disruptive doctors that I want to share with you guys. First, if you're a doctor who's thinking about moving into a non-clinical career but don't know when to start, or even if you're a doctor who's on the fence thinking if you should leave medicine or stay, the non-clinical career pathfinder by Disruptive Doctors is designed specifically for you. The problem why we doctors think that there's no opportunities for us out there is because we've been trained in sick care all our lives, but that's not true. Healthcare is a huge ocean. What you learn in this workshop is discovering yourself, where to find all the opportunities within healthcare, your game plan, and insights from me and Vivek on how to do it. And the best part is it comes with a 14-day guarantee. By the end of this workshop, you gain so much clarity on what you need to do, or if staying in medicine or leaving for non-clinical practice is for you. Our proven framework has helped more than 1,000 doctors on finding a fulfilling career. So stop wasting your time trying to figure it out all on your own in the dark. So sign up for our next workshop on our website. Next, mark your calendar for Disruptive Doctors Annual Conference and Exhibition. It's happening this 20th and 21st of September. This conference isn't about fitting into label. It's about expanding what is possible in healthcare and reimagining the doctor's role in it. This is where forward-thinking doctors come together to drive real change in healthcare. For those who refuse to settle, this flagship event brings together doctors from diverse backgrounds to explore fresh approaches, share ideas, and connect with a community of doctors to impact healthcare differently. Remember to get your tickets on our website at disruptive-doctors.com/conference 2025. And finally, if you haven't already, please download the Disruptive Doctors app. It is a global hub where you can connect, collaborate, share experiences with doctors across the globe, and you don't have to be limited by geography. This is more than an app, it's a movement. So be part of the community of doctors who are impacting healthcare differently. And also, can you do me a huge favor? If you have not subscribed to the channel yet, please be sure to subscribe, because it's subscribers like you that help us bring better guests for you. So whether it's the workshop, the conference, the app, or just subscribing to the channel, be sure to do it now. Now, let's get back to the conversation. Okay, well, speaking of the healthcare system, the healthcare system in the US is complex, and what I gather for many doctors is deeply frustrating, and because the biggest challenge is the influence of insurance companies on where patients can get treatment, what treatment they can get. And it's not really decided by the doctors. It's decided by the insurance companies, because whether you'll be covered or not covered. And recently, at the time of this recording, the United Healthcare CEO was outrightly assassinated. And I mean, that assassination made headlines, right? With people venting out their frustration to towards the insurance companies because it's controlling healthcare. So for you as a doctor in the system, what has this experience been like?
Okay, yeah, so that's a great question. The good thing is that the insurance companies, so there are multiple levels at which they supply. So let's talk about the different levels at which the insurance company situation may be applicable to a given scenario. So I work in the hospital as an inpatient internal medicine doctor, which we call a hospitalist in the United States. And my job is to admit patients from the emergency department. And I act as a hospitalist, which is a general internal medicine doctor, and I treat them. And if I need specialist opinion, then I bring specialists on the case like cardiologist, gastroenterologist, nephrologist, neurologist. And together we take care of the patient. And then when the patient is stable, the treatment has finished, then I discharge the patient home. So that's the inpatient situation. Now, what's the outpatient situation? The outpatient situation, again, is a kind of similar for internal medicine doctors. The patient walks into your office as an internal medicine doctor, and you go and evaluate the patient and talk about whatever is going on, what are the presenting complaints. And then if you need to bring a specialist on the case, you do it, but it's all done in an outpatient basis where you have to make an appointment and go and follow up. So the first area where the insurance company situation may come into play is that, again, let's talk about the same thing. Like if you want to get an MRI scan on your patient, now the insurance company may have certain criteria. Suppose you have a patient with low back pain, very common complaint in the population that I treat. If you have a patient with low back pain and the patient has some signs for radiculopathy and you want to get an MRI of the back, suppose you want to get an MRI of the lumbar spine or the lumbosacral spine, then as an outpatient doctor, the insurance may not approve it right away. They may want you to give the patient a trial of pain medications, physical therapy, then do an X-ray, then do a CT scan, and then do an MRI. So there's a long path that you have to take before your MRI request will be approved. That's what I've heard, because actually, as a matter of fact, I've never worked in an outpatient setting. Now, as an inpatient doctor, things are much easier. Obviously, we don't want to order MRI scans on each and every patient, right, left, and center. You have to use some sort of clinical judgment and discretion. But one of the reasons I work as an inpatient doctor is that I am able to order the test that my patient needs, and I do not need to get prior approval from the insurance company in the hospital setting to get the test done. And that's really the big reason why I work in an inpatient setting, because I'm able to order the test that my patient needs without a prior approval from the insurance, which I think is not the case if you work in an outpatient setting. Now, the other side where the insurance company's situation goes into play is when the treatment is finished and the patient is discharged and a final bill is prepared for all the costs that's related to the hospitalization and is sent to the insurance company, then it depends upon how much of it they are going to pay and how much of it they are not going to pay. And that's a very complicated situation anyways. It depends on different diagnoses. It depends on different insurance companies. It depends on the severity or the criticalness of the care that was provided. But that's something that I'm not directly involved with on a day-to-day basis because I'm an employed physician. So I provide care, I put in my charges, and I'm paid as an employed physician. So I don't get paid any more or less depending upon what the insurance has paid for my patients. So it is true that insurance company denials and those kind of things are a reality in the United States, but it's not in all settings. And especially the setting that I practice in, it interrupts my workflow the least.
I see. I mean, that's a very good perspective to bring up because, right now, the social medias with flurry on how insurance company have been denying life-saving procedures and treatments to patients.
Right. So most of that plays out on an outpatient side where you have to get a prior approval for any kind of procedure, any kind of surgery. Like again, as physicians, we know that some things are emergent, right? If you have somebody who comes to the ER with a gunshot wound, you don't have time to get insurance companies prior approval before you take the patient to the operating. Or if somebody has an appendix that has ruptured, there's no time for you to get insurance approval. So in the hospital, as a doctor, you still have a lot of ability to get things done because things are considered more urgent and emergent when you are in the hospital. And most of the insurance company prior approval situations play out as an outpatient. But again, that's not just limited to the testing and stuff. That also is important for the cost of the drug that you are prescribing, right? Because some medications are more expensive, some medications are less expensive. You may want to give your patient a more expensive medication, but the insurance company says, no, we're not going to cover that because we want you to use the cheaper alternative first. And if the patient fails that cheaper alternative, only then we will pay for the expensive medication. So there is a lot of nuances to this debate, and it does hamper the care that's being provided, but it's a constant challenge. And I think we all have to work through this. Now, it's very easy to cast blame on the insurance companies, but remember that whenever there is an argument between two sides, it's very, very unlikely that one side is 100% right and the other side is 0% right. There's always going to be some positive or negative arguments on both sides. So there are possibilities when there might have been doctors who have ordered excessive treatments or prescribed expensive medications when the same kind of disease could have been treated with less costly alternatives. So that also contributes to healthcare expenditure. So at a certain level, there has to be some sort of supervision about the tests that are being ordered by the doctors and some sort of justification. Somebody has to look after that too. And so it's a very delicate balance, but we have to look at both sides. But it's an ongoing conversation, and I think it's going to continue to go for a long period of time.
Yeah, because from what you are telling me, it sounds like they have to balance between defensive medicine and also insurance, the treatment that you want to give to your patients.
Right. I mean, it's a balancing act because there are many players in the healthcare field and everyone has their own interests. And you have to make sure that you can provide the best care, making sure that all parties are satisfied or at least provide justification. Well, one of the things that the insurance companies do is that they ask for justification. And sometimes that justification is reasonable and sometimes the justification is unreasonable. So at the end of the day, what is the important thing is that you make sure that the justification is provided, but you also want to make sure that they don't ask for justification for every single thing. Otherwise, if you are a physician and you have to do so many prior approvals, you'll probably never even able to go home. You'll be working 24/7.
Can you share a case that you have encountered or that you know of where, like what you just mentioned, pre-approvals, denials of insurance denials? Do you have any cases you've personally encountered?
Actually, I don't have any cases because, again, as an inpatient physician, I am easily able to order the test that my patients need, which is one of the reasons why I do inpatient medicine. So I don't have to get into that situation where I want to do something and I don't have the authority to do it because the insurance is requiring a pre-approval. And that's why really I don't have any of those cases, because if I feel like something is necessary, then I go ahead and order it, because at the end of the day, I want to make sure my patients get the best care that they need.
Okay, so you built quite an incredible career in the US, but I imagine leaving Pakistan, the place where you were born, you were raised, it's not a difficult, definitely must have been a difficult decision. How do you feel about, having left and not serving people in Pakistan? Do you feel like you may want to go back there and contribute to the healthcare in Pakistan in some way or another?
Definitely. That's a very important question. Yeah, exactly. I mean, there are so many ways in which you can make a difference. Just actively practicing and treating patients is just one way. But, you know, I'm so happy that we live in an age where there is internet and you can make such a big difference in the lives of people, even if you are millions of miles away with the power of the internet. And I am currently actively involved in medical education and also building a brand for myself on internet. And ultimately, what I'm trying to do is to build a platform that I can use in the future to impact healthcare on a global level, which will go far beyond just the US or Pakistan. It will be something that I will be able to make a difference all over the world. Obviously, it's at a limited level right now because I'm still trying to build the platform, but it's coming pretty fast. And very soon we'll be able to impact a lot of things. And then, obviously, when it comes to Pakistan, one of the big things Pakistan needs is also you have to make sure that you have to make people aware about the challenges people in that part of the world face. There's a lot of international assistance that's going to be needed. There are a lot of the way healthcare is practiced over there needs to change. Now, if I had not come to the US and I did not get experienced about the good things that the US healthcare system have to offer, then how would I ever be able to experience it and maybe talk to somebody in Pakistan and advocate and say that these kind of changes you need to make over there because that's what's working over here. I had to first come here and experience it, but now when I have this experience, then I can use it to make a change back home in Pakistan, which is one of the things that is on my list of things to do. And I'm pretty confident that sooner or later, I will be able to make a difference over there.
Okay, so what is your role now exactly? Like, what do you do? What are your projects?
So, I, at the most basic level, obviously, is still I'm practicing full time, seeing patients in the hospital and treating them. I also am the director for medical students. I teach them internal medicine. That's my primary specialty. And they come for their clinical rotations. I take them on rounds with me. We see patients, we discuss cases, we develop differential diagnosis, and prepare them for the USMLE. In addition to these two things, I'm also actively involved in sharing cases online. The biggest platform that I'm currently sharing cases on is LinkedIn, where I've been posting now for more than 6 months. And I share 3 posts every day, one clinical case, one poll, and one video post about different topics about medical education. And a lot of people really like it. My audience has grown by about 5,000 followers in the last 6 months, and my posts have generated more than 2 million impressions in the last 90 days. The reality is that medical education in many countries in the world still lags far behind many of the developed countries. So it's important for all of us to continue to provide the necessary medical education, even if it's in an informal setting. So you see, the problem is when we talk about medical education, we think that all the education that has to be provided in either a medical school or a medical college. That's not really the way it should be. Is everything, does everything that you've learned in your life, was that just by spending a few hours in school? No, right? Because you learned things when you went home, you learned things when you interacted with your parents, you learned things when you were going out with your friends. Life is a constant learning experience 20 hours a day. Every single moment that you are awake, you are experiencing something, you are learning something. What I want to do is to shatter this myth that medical education can only be provided in a medical school or medical college. We can have a lot of positive discussion on the internet about which treatment modalities are good and which treatment modalities are bad, or what diagnostic strategies are good. You see, the thing is that when you are discussing these things on the internet, you may be discussing it with somebody who has certain techniques available in the part of the world they live. And then there may be some people who are in another part of the world where some of the techniques are not available. So you can have a broad conversation and you can educate people based on their own settings. But this is just the platform that I'm laying down right now on clinical medicine. But I think what I want to do in the future is to sort of develop more awareness and spread knowledge about healthy practices. One of the most common things that I want to highlight is vaccination and preventive care. So vaccination has become such a controversial topic after the COVID pandemic. And, in the United States and over many countries in the world, there were groups of people who were fiercely opposed to COVID vaccination. And there were many waves of COVID where people unnecessarily died because they had not got vaccinated. If you remember the Delta wave that came, killed a lot of people, the Delta wave came after the vaccine had already been introduced. And a lot of people didn't get vaccinated and died from the Delta COVID virus. So the important thing is disinformation. There is a lot of disinformation out there, even in the medical field. And as a doctor, I believe that it is all of our responsibility to shatter the myth. We have to combat the disinformation to make sure the right information is provided to the people so they can make better decision for themselves as well as their kids. And vaccination is just one small aspect of it. Let's talk about preventative care. Vaccination is a big part of preventative care too. We provide measles, mumps, rubella, whooping cough vaccines to all the kids. But other than vaccines, what about routine blood work, blood pressure checks, diabetes? Remember, if you prevent a disease, that's the most cost-effective strategy because then you don't even have to spend a single dime on treating it. And preventative medicine is lagging so far behind in the world. So these are the kind of things that I really am worried about, and I want to make a difference on a global scale. And obviously, building a platform, a digital platform on the internet is just the first step in the process.
So yeah, I think I understand what you're saying because as a medical doctor, this information, even for medical practitioners are there. I know what you are saying about the COVID vaccine, but I've also encountered a lot of cases with adverse side effects towards the COVID vaccine. Pfizer refused to put out a full disclosure or report on their vaccines. There's so much of distrust in the industry right now because it feels like the pharma is pushing for their agenda, trying to make money. I mean, that's what's going on out there. And then for us doctors, those who have never been exposed to anything else, we believe what we were taught by the pharma companies. But there are those doctors who are fighting back, saying that, hey, I've seen too many bad side effects on my patients who are receiving COVID vaccines. So maybe we should start questioning what's being fed to us. What's your thoughts on that?
So I think it's at an individual level, I think all of us as doctors have different experiences based upon the patients that we have treated. As far as the patients that I've treated, I had a very positive experience with the COVID vaccine. I was able to save many more lives than the side effects that the patients had. So I think overall, it was really worth it. The thing is that what you have to keep in mind is the development of the COVID vaccine obviously had to be rushed because it was a pandemic. Now, just have to keep in mind that if they had more time to test the vaccine, then obviously some of the side effects could have been reduced, if not completely eliminated. But our backs were pushed against the wall because people were dying right, left, and center. At the end of the day, my experience with the vaccine was good. A lot of my patients were saved because of it. Now, obviously, there were people who had side effects and reservations. And again, I think at the end of the day, having a conversation and discussion that takes into account arguments from all different sides of the spectrum is really helpful. And that's one of the reasons why putting a brand or building a brand on the internet is important, is because you can hear the arguments from different sides of the spectrum, and then people can decide which way they would like to go, provided there is adequate information from both sides.
Okay, so earlier you mentioned that you like sharing cases while you're teaching. What's the most interesting case that you came across?
So, there are like one of the cases that I came across that I will always remember. That was actually a case that I actually have had in real life. And I had this patient that had a history of recurrent urinary tract infections. And she came to the emergency room, and she already had positive urine culture in the previous admissions. And this was just labeled as a urinary tract infection with abdominal pain, secondary to cystitis or pyelonephritis and stuff like that. And the patient got admitted. And I picked up the patient the next day, and I went and I saw the patient. And she kept telling me that her pain is getting worse and worse and worse. And so I was worried about it. So I did a CT scan of the abdomen, and I found that the patient actually had acute appendicitis. And actually, it was a pretty bad case of acute appendicitis. So I had to consult the surgeon immediately, and the patient went to the operating room and got a laparoscopic appendectomy, which was very timely because the surgeon told me that if we had waited even a few hours, the appendix would have ruptured because it was pretty swollen and distended. The reality is that sometimes you can have these kind of cases. And one of the things that as clinicians, we have to keep our mind open is that every case is different. So I think in this case, you had a bias. The emergency room doctor had a bias because the patient had previously been treated so many times for urinary tract infection. It was easy to label another abdominal pain as a urinary tract infection. But then you just have to realize that every time is not going to be the same thing. So I come across this also very frequently in my dialysis patients with elevated troponins. So, troponin, the bad thing about troponin is that it's not very specific. It's very sensitive for myocardial damage, but it's not very specific. So a lot of times I have dialysis patients with elevated troponin, and they come in all the time, and the troponin is unreliable. But then, you may come into a situation where the patient is actually having an acute myocardial infarction because guess what? The most common source of mortality in dialysis patients is cardiovascular disease. So you keep ignoring those troponins again and again because they are always elevated. And then one of the times you get a patient who has a real MI, and you don't want to miss those because obviously it could be life-threatening. So I think there are a lot of nuances with medicine, and you can always be surprised. But that's why it's important to always keep a broad differential diagnosis. And that's what I teach all of my medical students every time.
Mentioning the patient on dialysis, I had this one interesting case. This lady, she has end-stage renal failure on dialysis. She came into the hospital. I think she had some abdominal pain, and we thought she was having ascites. We were about to do a peritoneal tap, and she delivered a baby. So she didn't even know she was pregnant. I'm not sure how. She told us she does not know she's pregnant. She just came and it looked a little distended. And we just thought maybe it is. But when we did the scan and all that, I was like, oh no, there is a baby in there.
Yeah. Actually, I've never encountered a patient like that, but I've actually heard about some stories of patients going to the ER and delivering without going 9 months. And they just thought that they had a distended abdomen. Maybe they had some gas or indigestion or some, abdominal distension, and they never even thought that they were pregnant. And the pregnancy was diagnosed on the day of the delivery. So it's quite striking, but I'm sure it has happened at many different places around the world.
Yeah, that was a very interesting case because I was still a junior doctor and that was my patient. So, okay, you also did, one of the things that you do is medical algorithm to simplify complex diagnosis and treatment. So tell us about that. What inspired you to take this approach and what exactly is that?
So I always, when I was studying or when I teach my students, I feel like algorithms are very helpful because they create a structure which you can easily follow. And if you go down one pathway, things go this way. If you go down another pathway, things go that way. I always thought that it really helped me learn better if I could create an algorithm. So then I started doing algorithms on my own for everything, leading from physical examination findings to laboratories to treatment decisions. And I realized that I was learning much better by creating algorithms, as many as I could make. And so I realized that maybe, so one of the things that and I know as doctors is that the textbooks of medicine are full of algorithms. I mean, there are many algorithms. But the thing is, what I realized was that there are just not many enough. There could be many more diseases that can be taught much more effectively if you have an algorithm in place. So I decided that I was going to build more algorithms. And so I approached different publishers with this idea that I'm going to build more algorithms. And what I decided was that I was going to do a 10-minute video for every algorithm, because obviously the best person who can explain an algorithm is the one who has made it. So I had the best perspective. So I was going to explain my own algorithm in a short 10-minute video. And so there was a publisher that was interested in working on the project. So I worked with them. I think I ended up making like 40 or 50 algorithms on my own. And that project was very rewarding. But after a certain period of time, they didn't want to do it anymore. So I wasn't able to continue. But I think at some point I want to get back with it. I think internal medicine or any field of medicine can really benefit from algorithms. And one of the things is actually, I see a lot these days on the internet, there is a demand for mind maps. There are a lot of websites and there are apps that are out there that help you create a mind map. Well, the mind map is nothing more than just an algorithm. I mean, it's the same thing. They create a mind map from left to right. An algorithm, if you do it, it's usually from top to bottom, but it's the same thing. Because if you just stop for a second and if you just think about how your mind works, all of our minds work in the shape of algorithm. If I do this, then this will happen. If I do this, if I do A, then B will happen. If I do X, then Y will happen. So we always know it. What is life all about is the choices we make. What are the choices? The choices are the algorithms. Should I go to school or should I go have a party? And then down the road, you realize what's going to happen if I go to school? What's going to happen if I don't go to school? Life is all about algorithms. And so I thought that the application of algorithm to medical education can be a very useful tactic to make sure people learn the most in the shortest period of time.
So would you say it would be useful even for practicing doctors?
Definitely, because now we live in an age where we have electronic medical records, right? But the thing is that electronic medical records have their own algorithms. So they are based on the algorithms too. You can call it decision-making tree, or there are many different ways where you can put the name algorithm. You can call it a flow sheet. It goes by different names. But practicing doctors, definitely, why not? I mean, we make these choices every single day. Like if you have a cancer, we talk about if it's, all of oncology is algorithms that cancer is less than 1 centimeter, then you provide this treatment. If there is a local spread, you provide this treatment. What is that? That's all algorithms do. Every disease process, you can break down the treatment and even diagnostic techniques. Okay, you can do a blood count, and if the blood count is this much, then you do an X-ray. If the X-ray is bad, you do the CT, stuff like that. I think it just has to be standardized. And one of the things that I think is helpful is that if we have more algorithms, then we can standardize a lot of things across many different countries and different healthcare systems, because we can have a basic algorithm that takes into account the most basic facilities that are available in most countries. And then we can have a more advanced algorithm for people who have better access. There is a lot of ways you can play this game, and I think there is a lot of scope for improvement. But obviously, it's going to require initiative from the people who are ultimately responsible for spreading the knowledge to get this idea and to execute it in the proper fashion.
I think that's a very brilliant idea, because how patients are treated, say, in the US, where you have access to so many treatment protocols, diagnostic tools, but in developing countries like yours, it's so basic, so you don't know how much of that protocol you can actually implement there.
Exactly. So you need different algorithms for different for different areas of the world. And that's also a good way to know what are your limitations. So if you are in a place where you need a different algorithm because you don't have the resources, then you should be working towards getting those resources so you can get to that point where you can use the more advanced algorithm. It gives you a target. If you have a different algorithm, then you have a target to achieve. If you don't have a different algorithm, you don't even know what to achieve.
Okay, so for doctors who want to do more in healthcare, whether it's teaching, innovating, or creating something meaningful, what's your advice for them?
Right. So my advice is that all of us should have an active voice on the internet. And basically, you have to flow with the times. The internet is not going to go anywhere. It's only going to become more and more a part of our daily lives. What I want doctors to do is to get out there and start talking about things that matter to them. It doesn't just have to be medical education. It can be healthcare at any basic level. It can be access to resources. It can be implementation. It can be planning. It can be policy. What I want doctors to do is to choose what is most important to them in the whole healthcare landscape and start talking about it, but talk about it online. And the basic thing that it starts with is building an online brand. I think every one of us who has something to say can build a brand for themselves. If you have some knowledge, if you have some expertise, if you know about something, then guess what? There are people out there who don't know that thing and want to hear what you have to say, but you have to go out there and say it. So what happens is a lot of people who know a lot of things, they go to work, they talk with 15, 20 people at work, 30, 50 people. They come across maybe 200 people in a year. And so their ideas are limited to 100 to 200 people. But if you go online, your ideas can reach 100 million people. What I want doctors to do is to get online, start talking, build a brand for yourself. I mean, at the end of the day, just like you said, I mean, people are different. All of us, our DNAs are different. And all of us are different in terms of what are the things that are important to us. Why does one doctor want to become a cardiologist and the other wants to become a neurologist and the other wants to become a surgeon? Why don't all doctors want to become cardiologists? Right? Because we are all different. Some people like one thing in life, some people like a different color, some like a different color. That's how humans are made. So the point I'm making is that I talk about preventative medicine, I talk about vaccination, but there may be doctors out there who are not interested in these topics. There may be doctors out there who are interested in imaging, or there may be doctors who are interested in other form of modalities of treatments. And the landscape is very big. So what happens is when you go online and you build a brand and you start talking about something, you attract the people that want to talk about that. And you build your own tribe and own circle of people that are interested in the things you talk about. And that circle can grow and it can reach millions of people. And then you have a platform where you can say something and people will take notice. If you have 1 million people that are saying the same thing as you have the power in numbers. And if you say something, someone will take notice because they know 1 million people is saying that. But it's not going to happen if you just sit in your living room and don't go online and talk about it. So I want doctors to go out there, talk about the things that are important to them, build a brand, and make your voice heard. And at the end of the day, because at the end of the day, what do we all want to do? Or what do I want to do? What I want to do is I want to leave the world a better place than the one that I was born in. And by positive and constructive work and dedication, that's possible, but all of us have to take action.
Okay, so final question for all my guests. How do you see yourself impacting healthcare differently?
How do I see myself impacting it differently?
Impacting healthcare differently.
Yeah, mostly about providing education and awareness. What I really want to do is to provide more awareness, because I see a lot of patients every single day that don't even have any kind of mechanism to even check their blood pressure on a regular basis, something that's so basic. We've been checking hemoglobin A1C levels on patients for decades now to diagnose diabetes. And I cannot tell you how many patients I come across, even in the hospital, who've never had a hemoglobin A1C check, probably have had diabetes for 10 years and didn't know about it. So awareness is very important. And I want to make sure that people are aware of the food they are eating, that their lifestyle habits and stuff. And I also want to make sure that people are aware of the choices that they have. And a lot of times what happens is that people don't know what are their choices. You have to educate them about the choices that they have so they can make a positive decision. At the end of the day, I just want to use the online community to get my message across. See, when I go to the hospital and treat patients, I'm doing it at a limited scale. I can see 20, 30 patients in a day. In a month, I can see 600 to 1,000 patients, which is still making a difference in the lives of a lot of people. But if I can spread awareness online and talk about things that matter to me, that are so important for so many people, I can make a difference in the lives of millions of people. So the global audience is what really inspires me and encourages me to keep going. And I want to make an impact at a much larger scale than the local level, which is why really it's important to have a brand and talk about things online than only talking about it in your limited circle.
Okay, thank you, Dr. Kashif. Thank you so much for sharing your journey, your insights, and incredible passion for medicine and education. It's really stories like yours reminds us why we do what we do. Now, to our listeners out there, if this conversation has inspired you, don't stop there. Dr. Kashif is going to be on our Disruptive Doctors app, so be sure to download our app to test your medical knowledge with Dr. Kashif's medical quizzes. I myself have tried them, and they're really, really interesting and fun. It's not only a great way to learn, but it will allow you to remember what you've learned so far. And also remember to get your tickets to our upcoming Disruptive Doctors conference and exhibition where doctors drive real change in healthcare on the 20th and 21st of September 2025. Until then, keep exploring the stories beyond the white coat. And remember, it's not just about practicing medicine. It's about making a difference. Stay curious and we'll see you again. Thank you.
Join Disruptive Doctors.